Okay. Okay. So feel free to turn on your cameras or keep them off depending on your preference. Somebody is texting me that they are not able to join. Ta-ta. So we have to give at least one more minute because a couple of people are not able to join for some reason. Okay. I think we should get started because we are going to cover a lot of things. 12 of you are here, but let me get started. If somebody else joins, they are not going to lose a lot because we will be covering some background of this session today. Good morning, afternoon, and evening, depending on which part of the world you are joining from. And welcome to this webinar on artificial intelligence, AI-powered health research analytics, and paper writing. Human plus AI beats both. For those who are meeting for the first time, my name is Dr. Muhammad Farooq Ahmed. I'm a physician by training and by my profession, and a clinical researcher by training, profession, and above all, by my passion. And another ingredient which is very important to me, is teaching. But because of my professional commitments and my work in clinical research, I have not yet been able to devote myself fully to the structured teaching role. So I fulfill my passion through these occasional webinars. I just post the flyers on some of the social media pages where I'm a member of, and then a bunch of you then join um, through there. And I do it whenever my professional commitments are slightly lower than normal. Um, I also run some online courses which are of a more, I would say, again, if you're not talking, can I ask you to please mute yourself? Thank you very much. Coming back to our topic, AI-powered health research analytics. Okay, next, that was all about myself. And as far as let's talk about you guys. As I said, I posted this form at a bunch of places, and a number of you have completed that form. And I see very interesting statistics as you see on your screen. The people who have completed this form are from the United States, Ethiopia, Afghanistan, Malaysia, India, Ukraine, Saudi Arabia. A bunch of you are from the United States and Pakistan, which makes sense because I'm a member of most of the social media pages where most of the Americans and the Pakistanis are there. So that makes sense. But there are people from India, Portugal, Ethiopia, Saudi Arabia, UK, and Nepal. So quite a diverse audience are expected to join or already have joined. As far as your professional background is concerned, I see that almost half of them are related to the medical field. And then I see almost one third of you are, in fact, health professionals in epidemiology, research, public health, or related fields. And as far as your research experiences see, this is very interesting that I see that almost one third of you have co-authored a paper. That's very encouraging. Um, but I see a few of you have no experience, and there are a few experts here with multiple publications and first author, or have first authored a paper. As far as the epidemiology, biostats, or clinical research knowledge is concerned, I see um, maybe almost one third or more have some basic information, some basic experience in that area, and almost one third are intermediate level. And this is very interesting that 5% of you are professionals. So quite a diverse crowd here, which is very encouraging. And I have tailored this webinar to kind of being of use to all of you. So let's then go ahead with our content. First off, why this webinar even matter, right? So why you guys are even here? And my answer to you comes from this particular study that you see on your screen, Medicine Residents Understanding of Biostatistics and Results in Medical Literature. This was published in Journal of American Medical Association some times back, and the results are unfortunately very startling. These are the residents in the United States. I mean, these are residents. That means that they are fresh out of ovens, right? I mean, they're fresh out of their medical colleges, and they're still preparing for their board exam. So I expected slightly better results from there. But according to this JAMA study, if you see here, number 9, only 12% of them understand a very basic clinical research concepts like 95% confidence interval and statistical significance. Now, this is a very basic clinical research concept. And this is very discouraging that almost 9 out of 10 physicians, in fact, medical residents in the United States, which is a hub of research, almost half of the health research studies, 40% precisely, are being done in the United States, and almost no physician in the US can be in the profession without having a few studies under their belts. This is, I would say, a startling result. To begin with, it's just not unacceptable. I would say that this is dangerous. Gone are the days when it used to be the protocols and the textbooks which would drive your clinical expertise. And this is from the healthcare, from the doctors, and we don't have the data from the other healthcare professionals, public health workers, and other fields. But I will not be surprised if it is the same or even worse than this. And as I said, this is not only unacceptable, it's kind of a dangerous, because now the clinical research is coming so fast. There are almost one new more article every 20 seconds. And these protocols and these textbooks takes literally a decade to incorporate all those studies into the text for practical purposes. So whatever protocols you are saying, I'm literally involved with all these associations. I'm in this field for like 10 years or very closely with these people, worked with several years for CDC. I have worked for cancer institutes, and now I'm in the pharmaceutical world. And I see that these protocols, which you are reading today, are literally 5 to 10 years behind the clinical research, if not more. And this is going to speed up in the future. So I would say this thing that this is definitely, as I said, unacceptable. So let's move on, and then we'll come back to this topic itself. But I just wanted to highlight why we are even here and why this time is so critical. So as I have already covered this, why this is so concerning, but to health professionals, if I can advocate them, I literally do not blame them. I have learned clinical research myself. I went um, to the top university, I say for years, New York University, Columbia, Johns Hopkins, and it is not easy to comprehend. You need to have a very good understanding of clinical research itself. You need to understand biostatistics, which itself can take 6 months to 1 year. You need to understand epidemiology, which is again 6 months to 1 year. I took 2 semester courses on epidemiology. And on top of it, then you also need to learn some data analytical tools, which again is 6 months to 1 year. It can easily take. So it's just years and years of training, which of course is not that much of a possibility for busy healthcare professionals. And then the way it is taught, is very convoluted. As I said, I have gone to the top universities in the world, and still I struggled when I come to the practical field when it came to the application of all those concepts which I learned from all those hi-fi institutions. So I don't really blame them. I blame you guys about that. But here's the thing. This is a very interesting time, as we will see in the next 1.5 or 2 hours, that artificial intelligence is going to change everything from this point onward. And let me give you the practical sense of what I mean by that. This is going to change everything from this point onward. Look at this. Look at your screen. Look at this coding. I'm using SAS Studio for one of my studies here. This coding took me 6 months to almost 6 months to learn, and then another 6 months to 1 year to build some expertise on it. Very few people have this level of expertise that I have, but that is because I have a passion for this field. I have interest in this field, and I have literally spent, even after this much of expertise, I have literally spent whole weekend just to figure out a tiny bit of a problem in my coding. Whole weekend I just kept trying and trying and trying. Uh, there was some problem in my coding which was like 5 pages long, and I couldn't figure out. And luckily, after 2 days of my effort, I was able to find the error. And that's just not the frustrating part. The frustrating part is the results itself. Look at the results, which this when I submit this code, it spit out some results. For some reason, it is not showing. So let me refresh. Okay, here is the results. I mean, this is a very convoluted kind of a results, which again needs you to have 6 months to 1 year of training to understand what all these tables mean, and how to interpret these results. We were so much dependent on a team to run all these analyses for us. For example, what I'm trying to do over here is that I'm trying to measure the survival among the Black population versus the white population when it comes to the breast cancer
Yes.
survival. Uh, Again, please, could you please mute yourself if you're not speaking? Thank you very much. Okay, so what I see here is that after adjusting for race and age and subtypes and all these ingredients, there is 63% higher likelihood of dying for Black women compared to white women. My point is the complication which has been there, which was the reason why we had such horrible, and I'm going to use this word horrible results when it comes to the clinical research understanding. But here's the good news. That was the bad news. The good news is that this is going to change. This is going to go change so fast that that it is just magical. And I can give you some example here The same thing which took me years to develop this level of expertise to understand, to conduct such kind of analysis and then interpret all those analyses and then translate them into a paper format is way easier. And I can just give you a very quick demonstration of that. This is a different kind of data set. And you see how it is now, how easy it is now. All I have to say is there an association between BMI, your exposure can be anything, BMI, and I would say blood pressure categories after adjusting. I'm just using normal Excel, adjusting for age and say sex, male or female. And that's all I have to do. There goes my 10 years of knowledge, all my money, effort, and experience. Now, all of this can be handled by artificial intelligence and way more beautifully than I could do it with all my experience and my knowledge. And you see, it is already doing all this part. And we'll come back to it because it's a pretty hefty kind of calculation for Copilot to do. But we will come back to see what results it has come out with. And the beautiful part is that it can even interpret all those results for us and come up with some of our conclusions. And it can even help us in drafting the paper itself. Okay, so let it do its work, and we will continue with our conversations. So what are we going to achieve in next, say, 1 hour and approximately 45 minutes? I will like to start with some basic understanding of, and let me turn on my laser pointer. Okay, we will start with some basic foundation of health research, what health research study is, how to interpret the most important two values, p-value and confidence interval, what are the appropriate tests which are being used in health research analytics, and we will be using AI all along the way. So let me pause here and at least take one comment from you guys. What is your expectation? We might not have a lot of time. We will restrict it to just one or two comments max to hear from you. What is your expectation from this webinar? Anybody?
If no one else is speaking, then I can take the dare.
Sure. Go ahead, Vasu. You are my old friend. Yeah.
Thank you very much. My minimum expectation from here is to learn about some tools that can enable me to calculate and to gather data on a subject that I want to. Since I am related with hyperbaric medicine and I want to collect data about diabetic ulcers and diabetic wounds, especially in the GCC region. So my interest today is to get some hands-on things to get it done. Thank you very much.
Awesome. Yeah, you're at the right place, Masood. We will try to cover as much as we can, though we have a limited time here, but we will try to cover all of that in today's webinar as much as we can, at least the overview, which might help you in to get started at least. Okay. And let me check if our results are already there. No, it is still working, and we already see some interesting stats being spit out by Oh, wow. Okay, so the results are already out, and Copilot is telling us, yes, there is a statistically significant association between BMI and blood pressure category after adjusting for age and sex. 95% confidence interval is this, and here is the interpretation. See, that's the beautiful part. It is saying that individuals with high blood pressure have, on the average, of 2.47 higher BMI compared to those with normal blood pressure after controlling for age and sex. There are some more complicated um, statistics at the bottom, and all you have to do is ask, what is R square? What is F statistics? What is sample size impact on the study itself? But oh, wow, it is already telling us here that the BMI contributes to almost 12%. The impact of BMI on blood pressure is almost 12% in our sample. Okay, so of course we know blood pressure is also has a component from genetics, from your diet, and from a bunch of other exercise, your stresses. So the contribution, according to our data, to the blood pressure, as far as BMI is concerned, is 12%. So beautiful, right? Isn't it interesting? I do want to hear a couple of wows. I mean, it just is flabbergasting to me. Awesome. Okay, we got a couple of thumbs up, which is beautiful. So let's move on. We'll be using Framingham Heart study for our work today. And let me pull up. Anybody heard about this Framingham Heart study in their life before? If not, it's fine. Please ignore this background. My daughter, she keeps changing it whenever she gets it. That's her naughty thing for me. Okay, so that's the map. These all see my screen. There's almost, I'm gonna look for the Framingham town. Framingham, Massachusetts. Because of multiple screen, I'm losing my mouse again and again. Okay, Framingham is a small town. It's almost 4 hours from my home, close to New York. This town is in the suburbs of Boston. This town I'm showing you because it is a very important in health research. There's one of the most beautiful study going on in this town for almost last 80 years, 78 years to be precise. A Framingham heart study. Very popular study. It started back in 1947 or 48. When did it start? About, okay, 76 years. This study is going on. I think this is the longest epidemiological study going on since 1948. What the researchers did is that they recruited approximately 5,000 individuals between the age of 30 and 62 back in 1948, and then they followed them along all their life, collecting the data at the baseline and then every 2 years until their death. And in between, then they also enrolled their offsprings and then followed them along. And as we saw in the previous screen, currently it's the third generation which is being followed, exam 4 of the generation 3. So it's their grandchildren which are currently being followed. A lot of things which we know today about cardiovascular health is coming from this one particular study, including, the LDL and the HDL concept that also comes from this study. There are thousands of studies papers which are published based on this particular study, and we will be using one of the data set from this this study. The analysis which we just did is also from the same study. Okay, these results are also from the study. So, what is a health research study in itself? See, Framingham town has, I don't know, 70,000 or 80,000 population. Back in 1948, it might be whatever, 20, 30,000. And they enrolled 5,000 of 30 to 60-year-old in their study. I don't know which proportion of the whole population it was. And then they collected data on very precise elements which were of interest as far as the cardiovascular health is concerned. The data set that you see on your screen is from one of the data points. And the data set itself, this is a clean version of it. The way it is structured is normally each row represent one person. Okay? And each column represent one attribute of all the patients. Okay? For example, the first person is unfortunately dead. The cause of death other means that the person died of a cause other than cardiovascular. So that's an age chronic heart disease diagnosed. It is blank because this person never developed chronic heart disease. This person was a female. She entered the study at the age of 29. That's height, weight, diastolic blood pressure, systolic at the time of the collection of this data point. Smoking status, age at the time of her death, cholesterol level is not known at this data point at least, BP status, weight status, smoking status, BMI, smoking category, BMI category, cholesterol category, and blood pressure category. So what are we even doing? Some researchers, they arrived in Framingham town. They might have put on their brochures in doctors' clinics, maybe some grocery stores. People, they volunteered for this study. They enrolled them in this study. And then they started collecting these particular variables every 2 years, right? Now, what is the problem? The problem is that there are like 20,000 or 30,000 people who are of that age at that time, I'm just guessing. And even in the lives of those 5,000 individuals, there are hundreds, thousands of things happening all the time, right? Every minute, every year, people are dying, people are being born, there are stresses, there are neighborhood, there are genetics, there are food, there are traffic, a million things happen. We have just cleanly picked up whatever 10, 15, 20 variables from their lives. And now we have them very neatly put them in a data set, right? This is the life story or part of the life story of one person. And then this is the life story of second person or part of life of story of the second person, third and fourth and fifth. Now we have 5,000 life stories right here. Now we have to build another story, which is a combined story of all these 5,000 individuals, and we are looking for certain patterns. The problem is that we have already left out a lot of information from these people's life. Genetics, their neighborhood, their stresses, their diets, a bunch of things are already being left out. So my point is that as a researcher, we need to be humble enough to understand the limitations of whatever we find. This is our limitations and to some extent weakness also, right? So, but we need to be very honest when we put our results in our manuscript that what are the limitations of our study. Okay. Anyways, that's besides the point. But I just wanted to give you an overview of how the research study is even appears to be in the real life. Okay. Any questions at this point? Oh, I missed some of the points. I'm sorry about that. Okay. Okay. So let's move on. Let's start with a simple definition of research. It's a legal definition of research in the context of health. There might be different definition in elsewhere, but that's the definition which is given in a U.S. Code for Federal Regulation. Research means a systematic investigation designed to develop or contribute to generalizable knowledge. Okay, and this is a definition you will see almost everywhere. The important thing to note in this definition are, in fact, three. Research needs to be systematic. The way you collect your data, you analyze your data, you have to be transparent, you have to be explaining it, and we'll talk about that a lot in the next hour and a half. Second, a research should develop or contribute to knowledge. We are generating new knowledge, so that differentiates it from the clinical practice itself. In the clinical practice, we are not generating any knowledge. And the intent is to develop or contribute to knowledge, that's also an aspect of research. Third is generalizability. Right? So whatever your findings, they should be applicable to the population elsewhere. And we'll talk about that. This connects to the confidence interval, but these are the three major ingredients of our research. Okay, so how a typical research study even looks like in the real world? I'm trying to give you the crux of the story. A typical research study, how you will see in probably 99% of the cases. And you can remember this with this mnemonic 3+1C, and I'll explain in a minute. So a typical study is this. Is there a correlation or an association between the exposure of your interest and the outcome of your interest? Okay, so you have an exposure of your interest and you have an outcome of your interest, and you want to see if there is an association between the two. For example, your exposure might be smoking, and you want to see if smoking leads to lung cancer, right? So here your exposure is smoking, your outcome is lung cancer. Your exposure might be, as we saw this morning, BMI. Is it associated with systolic blood pressure? If the BMI goes up, does the systolic blood pressure correlates with that, right? Or you might have certain drug or a vaccine. You want to see if it has an impact on the prevention of a disease or the treatment of the disease. Or if you might want to see if there is an association between exercise and high blood pressure, hypertension. From social sciences, you might be interested in if women during pregnancies are subjected to certain kind of maternal stresses, does it affect the birth weight of their offspring? And from public health, you might be interested in knowing if the female education has long-term effects on the health of their offspring, right? So these are some of the examples of exposures and outcomes depending on which field you belong to. Okay, so what does it even statistical correlation means? Which simply as a correlation is the connection between your exposure and outcome. A positive association is that when the exposure goes up, your outcome goes up. Negative means that when the exposure goes up, the outcome correspondingly goes down. For example, you increase the dose of your drug, thus the blood pressure keeps falling, right? And no association is, of course, self-explanatory. So coming back to the elements of a typical research study, we all know all these studies. I'm just hurriedly going through the components of health research study, so we can then get to the practical work. But I just wanted to refresh your minds on how a clinical health research study is normally being conducted. So a research study in itself is a two-step process. Let me turn on my flash here. So it's normally a two-step process. In health, we are so much connected to the numbers. First, we want to see if there is a statistical correlation or association between your exposure and outcome. First, we do the comparison. We take two groups, one that was exposed and the other one which was not exposed. And then we see what were the outcome in those who were exposed versus those who were unexposed. For example, you want to see the systolic blood pressure between your exposure, male and female. You want to see what is the mean systolic blood pressure in male and mean systolic blood pressure in females. If it is different, that gives you an indication that gender has some association with systolic blood pressure. You want to see if your drug can reduce it can treat certain disease. Maybe it's a blood pressure disease. You give 50 patients your drug. You give 50 patients a placebo, which is an inert chemical, and you see if the blood pressure goes down in those who were exposed versus those who were not exposed. So that comes the first C, the comparison. The next C is covariates, and we'll talk a little bit about that in a minute. But because there can be other factors like age and sex and exercise and stresses and a bunch of other things which you need to adjust so you can compare apples to apples. Like the person with the same age, same sex, same stresses, same neighborhoods, and all that compared to the individual with all those similar attributes, can they have different outcome when it comes to just the exposure? One group was given medicine, the other one was given the placebo, and you see how much was the difference in these two very similar individuals. So that comes the confounders, and that's where when we ask Copilot to adjust for age and sex. So that's what exactly it was doing. The third C, confidence interval. So here's the thing. You have 50 individuals who were exposed, 50 individuals who were unexposed, and you see that there was a difference in the outcome in both the cohorts, the groups. In medicine, we call them cohorts. There was a difference. You adjusted for all the covariates. The difference was still there. Say the blood pressure of females was, say, 5 millimeters of mercury lower than the male. So can we conclude that males have higher blood pressure compared to females? Well, this is the results for only for those 100 individuals. We need to use statistical technique to measure the difference for the whole population out there. So that's where the confidence interval comes. Of course, we will never know with 100% certainty what is the actual difference in the whole 8 billion population of the world, but there are statistical techniques where we can estimate with 95% confidence how much is the true population difference in the whole in the people out there. And if that estimate does not contain zero, we conclude that this difference is statistically significant, and we'll talk about that in a minute. But your work doesn't stop there. Once you have established the correlation, there is another step where you have to establish causality, and it has a few other steps, as we'll talk in a couple of minutes. So we spoke about comparison, that this is, for example, if we are measuring the relationship between BMI and diastolic blood pressure, we see here that underweight individuals, which we say take as the reference value, the normal weight individuals have slightly higher mean diastolic blood pressure, and overweight individuals have even higher systolic blood pressure. So we already have some indication that there is an association between our exposure of interest and our outcome of interest, right? But what if we get the result something like this, that non-smokers have a systolic blood pressure? Here, the exposure of interest is smoking, and our outcome of interest is diastolic blood pressure. And if you just quickly look, we do not really see any pattern here, because we see that heavy smokers, in fact, have lower systolic blood pressure than moderate smokers. This can be just because of certain uh, Ahmed, so stop playing. Uh, so, I mean, the point is that there is no correlation, because we do not really see, at least in our data set, there can be multiple reasons. There can be some systematic failures there, that we do not see a correlation between smoking and diastolic as far as our data set is concerned. That doesn't mean that there is no correlation, but as far as our data set is concerned, we do not see a clear correlation between the two. Okay. Okay. And as far as the confidence interval is concerned, we already spoke about that it is the estimated range within which the true population parameter is likely to fall based on the sample. Okay. Moving on. And we spoke about that a little bit, that maybe the normal weight individuals have 120 mean systolic blood pressure, overweight individuals 130, and we see that there is a difference of 10 millimeter. But this 10 millimeter difference is for these individuals only, right? But then we use statistical techniques to measure the 95% confidence interval, which unfortunately 9 out of 10 physicians in the US do not understand. It's just the estimate of the population difference, population parameters. So we see here that in the actual population, the difference could be somewhere between 5 to 15. So even at the lower level, we do see a difference of 5 millimeters of mercury when it comes to normal versus overweight individuals. So we consider it statistically significant. And p-value is just a complementary value to the 95% confidence interval. If your confidence interval does not contain zero, your p-value is going to be less than 0.05. We are not going to cover the details of p-value here. It's a little bit more complex, but just so you know, the probability of finding this much of a difference is less than 5%. That's what the p-value means. Let me pause here again and take a couple questions, if there are any. Okay. So we can move on.
Farooq.
Yeah, please go ahead.
Yeah, quick question.
अस्सलाम वालेकुम फारूक, मैं एक क्वेश्चन पूछ सकता हूँ?
Sure. Would you be able to talk in English?
Yes, I will able to talk English. Let's say I want to conduct a study between the correlation of water intake and dizziness, yeah, vertigo. So this is my search question. I'm the population of persons who are not taking enough sufficient water per day have more chances of having the dizziness and vertigo oblique. So what type of study it will be? What you suggest? But first, if I want to write the research methodology or synopsis, what will be the study design in this case?
Well, that's a slightly different what we are covering here. We are really focusing on the analytics here, but when it comes to study design, it really depends on your resources. If you have resources, you go for prospective study, you collect primary data, you enroll 50 individuals, who are exposed and 50 individuals who are unexposed, or whatever your resources are. You might like to enroll 500 individuals, depending on how much money you have, how much time you have, how much staff you have, and you follow them along for 1 month, 2 months, 1 year. Totally depends on your resources. If you have no resources, you just go back and look for some of the secondary data from elsewhere and just apply the analytics, which is a quick, short way of doing it, but it totally depends on the resources you have. So, I mean, again, we can talk offline about that as a. Okay.
You mean that this will be a cohort study and prospective if I have more resources, and if I have less resources, it will be retrospective.
Yeah, exactly. Yeah, precisely that's what I mean. Right? Okay.
Yeah, Dr. Farooq.
Yeah, please go ahead.
Yeah, so I was talking. So just if you go back to this confidence interval and p-value, please.
Sure.
So with confidence interval of 5 to 15 millimeters, with p-value, it means the chances of having this range would be less than 5%, right?
Yep.
So it is actually other way around. The chances are it will be more than 95%.
The way p-value is interpreted, the definition of p-value is this. It is the probability of finding the research results or extreme just by chance. So what we are trying to see is that what are your chances of getting this much of a difference just by chance? Right?
Yeah, that's right. So, but in this case, when it is probability is less than 5%, that means it is very highly probable that you will find it. That means when you interpret it, it means that chances are it will be more than 95% that this range will be found.
The more than 95% chance is what?
So when you see probability less than 5%, it means the chances are more than 95%.
95% what?
Of this range, what you are referring to, in my understanding.
So p-value is connected.
Highly probable.
Yeah. 5% is.
When it is highly probable, that means p-value, it means it is kind of, it's highly probable. That means it's very favorable. The chances of finding this range related to blood pressure, to BMI.
Yeah, no, you are right. That's another way of explaining that finding this confidence is 95%, but finding this difference is less than 5%. That's what you mean, right?
Yes, but the way you interpret p-value, in my understanding, is that when p-value is less than 5%, that means the chances of finding any result is more than 95%. That means it's highly probable.
I think you are misinterpreting, but it's okay. We can talk about that offline if you are interested.
No. When p-value is less than 5, what does it mean?
Shraddh, we have to move on. We can talk about that. I mean, we are not debating here, but the chances of getting this difference of 10 millimeters is less than 5%. That's what precisely it means. So please do not confuse the people out there. But thank you for your comment. We have to move on. I know there's one hand up, but we have to
Can I
move.
please add to this question? So basically, p-value is the chances of a false positive rate. So if the study is like the null hypothesis, we consider it to be true, then there is 5% chance that this results is going to happen. So it's a false positive.
Exactly. You put it in the right terms. Thank you. I got it. So now it is.
You were asking about the power of study.
Yes. Chances of finding the false positive is less than 5%. That's correct.
Yes.
Or you can
Chances of finding this result chances of finding this result is more than 95%.
Power of study.
Okay,
Yes.
let's,
No, that will be power of study, and it will depend upon the
Exactly.
beta value.
Yeah.
So that's
So yeah. So when we say that the chances of finding any result, the null hypothesis, you reject this is by less than 5%. Thank you.
okay.
thank you. Thank you guys for your comments. Let me paraphrase for those who are interested. The finding of having this result being false positive is less than 5%. That's what our two esteemed colleagues means.
Thank you, Parvik. Yes, that's exactly the right interpretation.
Okay. Now that we have consensus, thank you very much for your comments, and this is a definitely good discussion. Okay, so let's move on to the covariates. We spoke a little bit about that we are measuring BMI versus systolic blood pressure, but it can be, the difference can be because of the age. Maybe the exposed group were higher age than on the average than the unexposed group. So we have to adjust for age. Maybe the exposed group just by chance had higher cholesterol levels compared to the unexposed. So, I mean, these are some of the covariates or confounders that we have to adjust, right? So that's the third C or the second C, depending on your sequence, that we have to take care of in our study, okay? Now, the second step is establishing the causality. And you will hear this term again and again in your research. Correlation is not causation. Okay, so once you have established correlation, that doesn't mean that there is that your exposure is causing your outcome. Okay, more correctly, we can say that correlation alone is not causation. You need additional criteria to fulfill before you can, with confidence, say that there is a causal relationship between your exposure of interest and outcome of interest. And that's where most of your discussion part of your study comes. The most popular criteria which is used is Bradford-Hill criteria. There are a couple of others too, but this is the one which is most commonly used, which has the following conditions. Plausibility, meaning that there should be some biological mechanism through which exposure causes the outcome. Again, let me say this. You do not need all of these criteria to be part of your study, but more of them present in or defendable in your study, higher is the likelihood that the relationship between your exposure and your outcome is causal. Okay. Second is the consistency. Different studies at different times, places, and person should get to the same results. If there are some conflicts between your results and certain other studies, you should be able to explain what were the differences, which were the reasons for that conflict. That again goes in the last part of your manuscript, the discussion part, and we'll talk about that in a minute. Temporality means that exposure, of course, should precede outcome. Otherwise, how is it going to even be blamed for the particular outcome? Third, the strength of association. This is measured, in fact, statistically. Our R-square and correlation coefficients are helpful. We're not going to cover that part in these 2 hours, but if you're interested, I have some online courses on that. Biological gradient means that as the exposure increases, the outcome should increase. For example, if we are talking about smoking and lung cancer, higher number of smoking per day should have higher likelihood of developing lung cancers and vice versa. If you're using some medicine to decrease blood pressure, higher and higher dose of that exposure should lower the blood pressure correspondingly. I mean, again, you do not need all of them in one study, but higher the number of these criteria present in between the two, higher is the likelihood that the relationship is causal. Effective intervention means that when you remove the intervention, that might decrease the likelihood of your outcome. I mean, that doesn't mean that your cancer will reverse if you stop smoking, but it means that if you have not developed cancer yet, if you decrease the number of cigarettes you're smoking, your likelihood should drop. Again, you might not have all of these 6 present in your study, but more of them present, higher is your reasoning that these 2 relationships are causal. Okay, so we already covered how the data set even looks like. But when it comes to scientific manner, so once you have completed your study, you have collected your data, now you are putting up your results out there. So in a nutshell, what is a research study? It's your discovery. And now you are convincing your peers about your finding. And there is a certain structure which has been followed for the last whatever 1,500 years, that when you put up your manuscript, you start with an introduction, you explain your methods, and then you provide your results, and then you discuss your results in the last part. But when it comes to the actual study, you normally get the results first. You have your analysis done, you have your results, and then you sit down and start writing about it. In the pharmaceutical industry, that's what we do. We have a research question, we go to our statistician, they give us the results. And well, in the pharmaceutical industry, we have a amount of money, to be honest. So we have the medical writers who write for us. Of course, I will be fully involved. They will be writing the method, which mostly we provide from our side. They then write the introduction and the discussion. So that's the practical sequence. We will be covering mostly the results part in the next hour or so. But if there is some time, we might touch on the rest of the 3. The first thing in any research is the research question, and that can be this framework, PCOS, can be very helpful in devising your research question. The PCOS is the population. For example, in our example, it is the Birmingham Heart Study, the 5,000 individuals which were included in that study. Exposure, for example, if we are studying BMI versus hypertension, the exposure in this case is BMI, or it can be smoking or whatever. Controls are those who are not exposed. For example, we might be comparing those who have high blood pressure, high BMI, versus with those of normal BMI. In this case, the exposed ones are who have higher BMI versus those who have normal BMI. And outcome is can be systolic blood pressure or hypertension, depending on what analysis is most effective. And to your question, study design is an important thing. Study design means how you are going to collect that data. Retrospectively, you might be using some of the data which is already being collected, or prospectively, you go out there and you enroll the patients in the study and get the IRB approvals and follow along for a certain period of time, collecting the data at specified data points. So from where this comes the study design and the statistical analysis. If your homogeneous study is homogeneous, you might do non-statistical analysis versus the other one to Okay, so now we are ready to go ahead with our AI-powered health research analytics, given we have already have a good understanding of what health research study is and how we analyze it. So as I said, we will be focusing mainly on the analytics part, the results part, and if some time is left, we will talk about the paper writing. So let me pause here and take a few comments or question, and then if you want to take a water break, because from this point onward, we are going to switch gears. We are going to be in our third, fourth gears, and uh, I will request 100% of your attention from this point because everything is built on top of each other. So let's take a couple of minutes of break. I'm still here. If you have any comments or question, we can take those here, and then we will start with our analytics. Any questions, comments? Shafat, are we on the same page? Yes, Paul, go ahead.
Hi, Dr. Farooq. Yeah, thank you for the session. So I have a question regarding the use of like AI tools. So that is definitely a very good approach, like for analysis. But my understanding, I wanted to know, like, say for an example, for any data set, for Framingham or for enhanced data set, when it is in like in raw conditions. So like making the data set perfect, I mean, cleaning and all everything. And after that, if we give like the AI tools to analyze this, that might be possible that, it can handle very well. But is that possible that I can do all those, like making a perfect data set, cleaning and everything, also utilizing the AI tools? Is that possible?
No, that's a very good question, and thank you for bringing that up. So far, I see that ChatGPT and all these tools have very limited capabilities, especially when it comes to relational databases, because the way the data is collected, they have probably 30 or 40 or 50 tables, and then you have to combine them, and then they are stored in as a raw data just to save space in the computer, and then you have to convert them into a clean version. And I 100% agree to up till now, this capability is quite limited as far as ChatGPT is concerned, but I see it changing very fast, very, very fast. For example, even in this data set that we were working on, where is that? I did a bunch of things just using Copilot. All these variables which are created um, from column Q onward are created by a Copilot itself. So that's a new capability Copilot has. I just asked it to uh, create a new variable BMI based on height and weight, and voila, it was right there. Boom, it was there, and that was a surprise for me that how fast these things are catching up when it comes to data cleaning. Good question. Thank you.
So, Farooq, thank you for this. The question is for data analytics, which AI platform is usually the best? There's a lot of somebody said it's Claude, somebody said Copilot does good job, but ChatGPT is good for writing, for example. Gemini is for something. So, in your experience, I don't know what you heard or what you experienced. Which platform works best for data analytics?
At this point, I would say Copilot. Copilot has caught up on a lot of its weaknesses. They started very late.
Good.
GPT had a huge jump start. Copilot, they started very late. And the way it is coming out is surprisingly, I would say, fast. And I think given that all of us use Excel and these Access and Power BI, I am sticking to Copilot. I used ChatGPT for good about 2 years,
Okay.
but now I'm switching to Copilot given the convenience it has.
Okay. So I agree. So because it's from the same group, like it's MS365.
Yep.
So yeah, that makes sense if they connect it with Excel. So I was just curious because somebody said Perplexity is also good for writing and analytics after reading that. But thank you for sharing your experience. Organizations have started their own AI tools to this. That's what I heard also, various companies.
I work for Johnson & Johnson. They used to, but they are rudimentary compared to the capability of Copilot and all. Because, anyways, okay. So let's move on. And as I said, I would request full attention from this point onward. I'm going to give you a kind of a crash course on health analytics in next, say, 10-ish minutes. And then we'll start using it in our analysis. Okay. So once you have that clean data set, as Paul said, you have it, you have collected your data, it is in a clean format in front of you. First, you try to run the descriptive statistics on this. The descriptive statistics, as the name suggests, describes your statistics. And let me explain what it even means. Now look at this data itself. What does it even mean? Although it's very clean, it has only few variables, it is very limited compared to the information out there, but still human mind doesn't have the capability to process this much of information. First person has a height of 62.5, second person has a height of 59.75, third has 62.5, and now I'm confused. What does it even mean? There are 5,000 values. Computer has the capability to process, but human mind doesn't. We want to summarize all these values so we can comprehend, because this data, and it is in fact the caption of this webinar itself, human plus AI beats both. We are developing or analyzing this data for human consumption, right? So we need to come up with some values which humans can understand. So we need to summarize all these values in some ways so it can be communicated, it can be compared, and it can be used for practical purposes. Does it make sense? Okay, so we have in the description, we summarize this data. And if you look closely, there are two types of variables here. Some are numbers and some are text. And some are hidden as numbers, but in fact, they are categories. Let me repeat. Some are numbers, some are categories, and there are some which appears to be numbers, but they are in fact hidden as categories. They are hidden categories. Okay. For example, look at the height value. These are numbers. Okay. Age at start doesn't have any points there. They are taking it as categories. 42-year-old, 58-year-old. There is nothing between 42 and 43. So the researchers, they are using these numbers as categories. We do not have cancer stages here, which cancer stage 1, stage 2, stage 3. These are categories hidden as numbers. So if we just say summarize, there are only two types of variables. And I'm saying this because we are going to summarize them in different ways. Numbers we summarize in different ways. Categories we summarize in a different way. Okay. So when it comes to numbers, I mean, again, zip codes, right? These zip codes are numbers, but they are in fact categories. Okay? So beware of those numbers which are in fact hidden categories. In the nutshell, we only have two types of variables. One are continuous variables, meaning that even within certain range, they are continuous. even between, say, the blood pressure of 110 to blood pressure of 111, it is continuous. There is 110.1, 110.001, 100.00001, 100.00002. So they even between the two numbers, they are continuous. Okay. Everything else is categories. I mean, another way of differentiating is that continuous variables are infinite, categorical variables are finite. So when it comes to continuous variables, we summarize them or describe them in at least two ways. We find the center, which is normally the mean or median, and how much spread they are. Spread, we use percentiles or standard deviations and ranges, right? So that's how we are kind of describing our data here. We might provide the mean height. For example, if we are talking about BMI, we provide the center, the mean blood pressure, the median blood pressure. We also provide the spread of the BMI that is measured by standard deviation, and but percentiles and ranges from this level, from this value to this value. Okay. But when it comes to categories, of course, we cannot take the mean of them. We cannot provide the measure of the percentile of them. So we summarize them, well, just by frequencies and proportions, right? So 2,000 males, 2,400 females. For example, 50 were non-smokers, 200 and this much were mild, they were moderate smokers. These many were very high smokers, and so on. So we provide the frequencies and the proportions: 50% males and 50% females, or 49.5% males, or 59 or whatever, 51.5% males. So my point is that when you have this data in front of you, first thing you want to do is to describe that data set for yourself and for your peers. Okay. And you also want to provide one of the visuals, right? That gives a picture of your data. So let's do this in Copilot. Okay, I'm gonna ask Copilot to describe. I mean, you do not have to describe all the variables, but at least the exposure of your interest and the outcome of your interest. These two, at least, you want to describe, right? So let's describe our exposure of interest, which is BMI. I'm just gonna write here, provide the descriptive. I'm just gonna be very open. Descriptive statistics of exposure of interest is BMI underscore CAT. I just want to see how many of them were overweight, how many normal weight, etc. So I'm just going to ask it to provide the descriptive statistics of BMI categories. Okay. So this is a categorical variable. And just sit back and relax, and it should give us some good BMI category description. I mean, previously, if I'm using SAS, either I had to write a code or use a point and click methodology and pick and do all those stuff. But now we can just use a natural language to do all those stuff. And it's going to take time. In the meanwhile, we can move on to the next thing. Okay, the results start coming out, in fact, slowly. We have given it a lot of work, so we need to bear with it. In the meanwhile, I can take a couple of questions or comments. Okay, the results are here. We see that, okay, it has done some bad thing here too. but we see that there are 2,555 individuals with normal weight and these many with overweight. So here is the frequency, and here are the percentages, and it is also giving us some other statistics. Interesting, right? We don't need SPSS, we do not need SAS at this point onward. Can I get a couple of thumbs up? Thank you, Shafat. Okay, let's move on. And let's use BMI category as a continuous variable. We do have the same thing as a continuous variable. So let's ask it to give us the descriptive statistics provide the descriptive statistics of BMI as continuous variable. That's all. Now it should give us the mean, median, I expect even mode, the standard deviation, the ranges, and I would expect percentile. We'll see if it gives us the histogram or not. If not, we can follow with an additional prompt. While it is working, let me just quickly show you an interesting thing. The prompt structure, it's not very difficult. It's because I just completed a course on prompts, and I just wanted to share you what is a good prompt looks like. Let me just write prompt structure in Copilot. Okay, yeah, so that's what the Microsoft recommends when you are writing a prompt. First, you provide the goal. I want to list three, blah, blah. Then you provide the context, what kind of results you are seeking for. Then you put the expectation, and then you provide the source of that information. Okay, so in this sequence, they want you to write your prompt, just as the Copilot was are kind of doing the heavy lifting for us. I just wanted to quickly show you, which I recently learned, that this is the structure which Copilot is recommending. Okay. So let's go back to our results. Maybe they are already out. Okay, so here is the descriptive statistics of our exposure of interest, BMI. We see that mean BMI in our cohort is 25.58, median is this, mode is this, standard deviation, variance, range, and it is also giving us all the percentiles. It has not given us the histogram, so let me ask the histogram. Provide histogram. So the way the prompts work, it first look at the prompt which was just given. So the one which was previously given. So it will take the context from the prompt which was just preceding your latest prompt. So it should be intelligent enough to understand which histogram I'm talking about. So I'm just wanted to test its intelligence here. Otherwise, it should have asked, what histogram are you talking about, right? So, but the way Copilot is structured, it goes back to your preceding prompt before going to anything else. Okay, yeah, so it worked. So it is still developing. The histogram is just listing them. It is putting all the BMI categories in certain bins, and we should expect histogram to come up any minute. There's too much silence out there.
Is this paid version or the pre one?
It's a licensed version. The
It's licensed.
cheapest
Okay, good.
yeah, it's the
Okay,
cheapest
because
version. Cheapest
free
version. I
ones-
think it's something like $100 per year for 5 computers.
Good.
So it literally is like $20 per year per computer, something. But you're right, you need to have a licensed version of Microsoft Office to have Copilot. I don't know if the unlicensed version they have some capability, at least to the basic capability when it comes to Copilot or not. But looking all those results for last, I started using it a couple months ago. I'm not going back to ChatGPT anymore. Okay, so
Good morning, sir.
yeah.
Sir, can I ask one doubt?
Sure.
Hello, sir.
Yep.
Hello.
Yeah, I can hear you.
Yes. Actually, sir, BMI, here we are taking it as a continuous variable. So actually, can we make it as category? Because from 18 to 20, one category, 20 to 23, one category, and 20 to 23 to 25, one category. So then the analysis will be changed, no? And before that, sir, should we check the normality? Because if it is a continuous variable and if it is normally distributed, we will go for standard deviation and mean. But if it is skewed, we will go for median and interquartile range, no, sir?
Man, look at the intelligence of Copilot. It's still there are some faults there, so the histogram for some reason did not come up, but it is already providing you the skewness here, right there. See? And Curtis says so. It is already telling you if it is normally distributed or not. And if the histogram had come up, we could have visually inspected for normal distribution or not. But I mean, it did faulted here, and we can ask it to do it all over again. Can you redo? Okay, so because we did not see the histogram coming up, I mean, it's taking its time. Of course, it's not 100% perfect yet to do all these things. Sometimes you have to go back and ask it all over again. But the analysis itself is 100% accurate. It does fault when it comes to the full generation of the report, so you might have to ask it to redo it and all those things. But now we see it. So now you see the histogram. You already see that it is skewed on the right side, and the skewness is right here. So it is already saying that it's positively skewed. There's a heavy tail on both sides. So approximately normal with a right skew. Did it answer your question, Divya? Was it Divya?
Yes, sir. But sir, actually, this is little skewness. But sometimes, if our data is little skewed, also, can we do the means? It looks almost normal, no, sir. We will get a means almost near bell shape.
Yeah, it is
Oh,
also certain tests like t-tests and which are quite robust to skewness. But as a business as usual, we normally run parametric and non-parametric tests together. That gives us more holistic picture. But it is just a normal practice in any analysis that if it is skewed or not skewed, we still run both parametric and non-parametric tests. I mean, that's beyond the scope of this webinar. Here I just wanted to show you how this analysis can be so conveniently now being done itself. Once you have the data, you can just run all these analyses. Yeah, so I mean, we can talk offline, Anika, if you want to talk about I mean, I will be running online courses, which again are free, and I will be sharing the information about that. There we go in the details of all those parametric, non-parametric, and all those tests. Okay. Okay, so. We ran the descriptive statistics both ways by continuous variables, where we found the center, the spread, and we also developed a visual, and we also ran a descriptive statistics for the categorical variable, where we saw the frequencies and proportions. We did not saw the bar chart, but we could have additionally asked for bar chart. Okay. Another additional analysis that categorical variables provide us are these so-called measures of association, relative risk difference, relative risk, and odds ratio. So let's ask Copilot to run risk difference, relative risk, and odds ratios for us. Okay. And I'm going to open I'm going to use the word provide, because provides the risk difference, relative risk, and odds ratio. I'm just using their abbreviations, and I'm banking on Copilot to understand. It should be intelligent enough from our previous analysis that it should be able to understand all these terms. For the exposure can be BMI underscore category, and outcome BP underscore category. Here both of them, we are using them as a category because we are categorical. We are doing the descriptive analysis for categorical variables. So I just wanted to show you that although the continuous variables to their face appears to be much more valuable, because we can measure the mean and the median and the standard deviation, the percentile and the ranges, and a lot of things. When it comes to categorical variables, we can just describe them by frequencies and just frequencies and proportion. That's it. But I wanted to show you that although on the face they appears very naive or kind of limited, but they give us an additional opportunity when it comes to analysis in the terms of relative risk, risk difference, and odds ratio. Okay, so let me ask Copilot to give me all those in a table, and let's see what it provides us back. By the way, I did not do it beforehand, so I'm also curious what it is going to give me back. So far, isn't it mind-boggling? Just imagine, I spent months and months learning SAS and the coding and all the problems I had to face with it, and then the biostatistics on top of it, and then epidemiology knowledge. And when it comes to the practical sense, it is an other struggle to combine all that knowledge in one. And I can tell you, not many people. I have worked in CDC and mid-senior positions in academia for many years, in pharmaceutical industry many years. Nobody understands these things, and we have the results there. But that was a threat. That's a history now. Now we are in a different era. Now, if you don't understand this, there is no excuse out there. You do not understand. All you have to know is, I would say, this just one slide. You just need to know that there is a continuous variables and how to describe it, categorical, how to describe it. And there are total 6 tests out there. Total 6 tests, which you will see 99% of this in 99% of cases. well, there is a PhD in biostats out there, but if you know these 6 tests, t-test, ANOVA, linear regression, chi-square, logistic regression, and survival analysis, you will be able to understand almost all research studies out there. All you have to know that there are 6 tests, and we will talk about all of them in next half an hour. So, okay. So we have the relative risk and odds ratio, all of them here. We see the risk difference. The risk of high blood pressure is 28.8% higher in overweight individuals compared to normal weight individuals. Here is the risk ratio, which is also known as relative risk. Please note here that this is 28.18 percentage points higher. Okay, it's not percentiles, it's a percentage points higher. Risk ratio is here. We see that those who are overweight has 97% higher likelihood, or almost twice likelihood of developing a high blood pressure compared to normal weight individuals. And when it comes to odds ratio, we see that they have approximately 3.2 times higher odds of developing high blood pressure compared to normal weight individuals. I mean, it just surprises me how beautifully it is not only calculating, it is also providing the interpretations in a plain English language. And here are all our results with the interpretations. All I asked is to run a risk difference, relative risk, and odds ratio. Okay. We have half an hour left, so we are going to cover all these 6 tests in half an hour, spending, say, 5-ish minutes on each of them. Okay, so that should be half an hour. Okay, so if your outcome is in continuous variable, for example, your outcome is systolic blood pressure, right? So actual continuous variable, you run continuous data analysis. If you are measuring it as a category, you run category data analysis. For example, and let me write here. For example, in our case, oh, I'm sorry. Let me turn on my pen. Give me 1 sec. Okay. So if you are taking blood pressure, for example, you are just taking systolic blood pressure, which is continuous, right? So if you are measuring if the mean systolic blood pressure between male and female, or mean systolic blood pressure among those who are higher weight or versus a normal weight, there is a difference. Here we are actually measuring systolic blood pressure as continuous, so you run continuous data analysis. But if you are measuring your outcome as a category, as we have is over there, high, why it is not writing, high versus normal blood pressure. Now, here we are having categories. I'm sorry, this is giving me a hard time here. Wow, okay. I hope you could read it. Okay, so now we are measuring in the second case as categories. So in that case, we run categorical data analysis. That's all you need to know. If your outcome of interest is measured, depending on the situation, you want to just see how much is the likelihood of increasing hypertension with high blood pressure, you might like to run categorical analysis, but you want to see the effect of your drug on how much systolic blood pressure drops in those who were given drug versus those placebo. You might like to measure the systolic blood pressure itself in the continuous. So depending on your research question, you can choose to run a continuous data analysis or categorical analysis or both. Okay, plain simple. Isn't it simple? Okay. Okay, so let's move on. Now, let's first run these 3 tests. So the main difference between these 3 tests is that when you're comparing for example, systolic blood pressure between 2 groups, higher BMI versus lower BMI, or males versus females. If there are only 2 groups, you run t-test. If there are more than 2 groups, you run ANOVA. I'm not going to go in the details of the mechanics behind each of the tests, but if you just remember that you have very homogeneous two populations, you just want to measure how much is the systolic blood pressure of those who were given the drug versus those who were not given the drug, you run t-test. You have given three types of cohorts. One was given, say, 50 milligrams of the drug. The other one was given, or say, one was given your drug, X, and then you compare it with those who were given, say, the standard of care, which is already there, and the third group is given placebo. Now you have three groups to compare. In that case, you run ANOVA. Okay? You want me to repeat? If you're comparing two groups, t-test. If more than two groups, you run ANOVA. Okay? Linear regressions, or these regressions, are the most powerful techniques out there. They just, when you read about their capability, you are like, why even I need to do t-test and ANOVA when linear regression is out there? Because it not only it doesn't care how many groups out there, it can also adjust for all your variables, age, sex, whatever. So it has a huge capability and amazing statistical technique. And if you join my online course, I explain all the mechanics behind each one of them. Okay, but why even we need t-test and ANOVA? Because linear regression is very difficult to explain, as I showed you in the beginning. Those million tables, you run different models, and then you have to defend why I chose this model over this model over this model. You provide all those models, and then you have to provide all the details of it. So they're complex. So if you have a simple two homogeneous kind of populations, you go for t-test or ANOVA, and it will be acceptable. But if you are going to FDA, God forbid, they want to adjust for all those variables. They want linear regression to be run. Okay, so let's do it here. I'm not even going to tell it what test it to use, and I will just see what it does. Okay, compare the mean systolic blood pressure, and this is our outcome, between two categories is of BMI CAT, right? It was BMI CAT. BMI CAT. Okay, so I want to see what it does and what test is going to use. So here we have only two categories. The BMI were, if you see here, column S, overweight versus normal. So there are only two. So I think it will use t-test, two categories of BMI underscore CAT. Okay, let's see what it does. No, my prompt wasn't that nice. It's just gonna give us the mean of both of them, but let's see what it does. Is it gonna run the t-test? It will give us the confidence interval and p-values, etc., or not? Let's see. You guys can unmute in the meanwhile if you want to comment. I just feel sometimes by myself if nobody's talking.
Farooq, I have a question. Just a brief one.
Yeah, please go ahead. Was it Kashif?
Yes, it's me. Like SPSS and SAS, they are like established statistical analysis data. But in which category do you think Copilot will exist? Because many researchers and many papers, they are a bit skeptical about use of AI. Though many one allows it, but still there are few which are not very in favor of that. So can we, when we say that what we are using, we consider we are using Copilot as a statistical analysis program, or still it will be considered an AI tool?
It is an AI, number one, but almost all journals for the last, I would say, 2-3 years have changed their guidance, and all they want is to be transparent. All they want is to be transparent. If you have used AI tools for your analysis, they just want you to explain how you used those analytical tools. And that was like a year or 2 years ago. They don't have any choice. I'm in this field. I do this thing for my living. They have no choice with these kinds of capabilities out there with AI. The journals, they need to accept this. I mean, they just want transparency at this point, what tools you used. And so far, all the analysts, because they have, like myself, have years of training on SPSS and SAS and all those, they still use them. I still use SAS for at least data cleaning purposes because that's coming up. But once you have a clean data set, Copilot is the way to go, man. Okay.
So for the sake of curiosity, Farooq, if you ask Copilot which statistical method they used, shouldn't they say exactly, explain?
It should. It did not, but let me ask, what statistical test
Or test.
did you use? It should say t-test. Let's see, because I see the results here. Because it is providing, there's, I mean, if there are two categories, oh yeah, t-statistics is already there, so it is using t. Oh yeah, here. All right, so it is using t-test. Okay. Now, right? So that answer your question? Okay,
Yeah.
let's skip ANOVA. ANOVA is the same, but if you have to say comparing, if you're comparing more than two categories, for example, where we have more than two categories. Yeah, weight status, you see, it has overweight, normal, and maybe underweight. I think there is one with underweight here. Weight status, yeah. So I mean, if you're comparing the say systolic blood pressure with three categories, it should run ANOVA, and it will give you the results accordingly. Okay. Now let's move on to the most powerful one, the legend of the legend, the linear regression. Okay. And I think it's going to take a very long time to measure because of the calculation. Okay. Is there an association between exposure, and I'm going to use the exposure as exposure can be any. The outcome should be a continuous exposure, BMI category or continuous. What do you guys think? Let's use category. Category and outcome systolic. Systolic after adjusting for sex and age. Okay, let's not give it too many. It's anyway a lot of work for it to do. Okay, now it is going to run a linear regression because the outcome of interest we gave it to is a continuous variable, systolic, right? If we have given it a category, then it will run logistic regression. You see systolic here, it's a continuous, so it will run a continuous data analysis. Okay, I think it will take good about 5 minutes. In the meanwhile, we can have some gossip. Feel free to unmute yourself and talk about it. In the meanwhile, I will take a break from talking. Okay. Okay. mean systolic blood pressure. It is going to take a long time because of tons of work that we gave us. But if we were doing it by SAS, no, it can easily take, I mean, our statisticians, this kind of analysis, they will tell us to come back in 2 weeks because obviously they have a bunch of stuff going on in their at their place too. But they charge for one of this analysis for at least 8 hours, 8 hours of work. That's how they charge us per table. And pharmaceutical, that means literally $10,000-$20,000 for one test. So I wonder if it is gonna put them out of job. Given that at least the young statisticians are very vulnerable with AI. I mean, the experienced one because they have the knowledge of the human aspects of the knowledge, but the new analysts, which are just entering, we don't need them. We don't need them anymore. I don't need them. I can run the analysis myself.
So there is this RAG concept now being added to LLM that increase the data cleaning efficiency, retrieval augmentation, generation of the AI system. So that's what different companies are now kind of adapting.
No idea. Can you tell us about that? Because the courses which I have done so far are mainly around the analysis part. That's my area of expertise, but I would be very interested in
Yeah. So definitely. So the thing is like, when you ask any question, any prompt to like, let us say about data cleaning. So the AI can do it, but how accurate is that cleaning, for example? So the companies or the technology has now introduced this retrieval augmented generation.
Wow,
That means
okay.
they confirm the
Yeah.
accuracy of the outputs from these bots.
Wow, okay.
So
Okay.
that's going to be a new system when you said we don't need statisticians anymore in the future. But unless we have that RAG methodology applied to
Yeah.
AI system, it will not happen until then because people
Yeah.
do not trust 100%.
No, you're right. I mean, how I am using right now is that I'm combining AI with my expertise in, say, for example, SAS. If it is not running, I will, instead of going to a statistician looking for what is wrong in my code, I run this code. I don't get the result. I just put this code in ChatGPT or Copilot, and it tells me that what could I just put the error in it too, that this is the error which is being given to me. And so that's how I'm combining human and AI. But once this RAG thing is out there, why when I need SAS, right?
No, absolutely. So I don't know what clinical scientists or medical scientists, other companies call them, what they are using right now. But this is the future trend.
Man, okay. I mean, yeah, sky is the limit. No, thank you. Do let me know about where I can learn more about it. Okay, so anyways, it is taking a long time because of the work it is doing, but even if it takes, say, 10 minutes or 15 minutes, compare it with a PhD team from Harvard or Yale doing the same work over 8 hours. And the cost, which, I mean, I told you they charge us around $10,000 for one table. And it is in tens of thousands of dollars each. I mean, for one study, in retrospect, even it cost us like $100,000, $50,000, and most of it goes to the statisticians. Okay, so the results are here. There is a statistically significant positive association between PMI category and systolic blood pressure after adjusting for age. Overweight individuals are nearly 10 millimeters of mercury higher systolic blood pressure compared to normal weight individual, and blah, blah, blah. Okay, we only have 8 more minutes, but I will stop at this point because probably we will be in between and we'll run out of the time. I do not really want to go beyond that, but I just wanted to share some of the learnings that I have over the last 2 years of using AI and how it is evolving over the time and these new capabilities which are coming up. I'm staying tuned about what new capabilities are going to be incorporated in next 6 months or 1 year. It appears to be 1 year, appears to be so long now. But let's stop here. And let's have some light chat. How does everybody feel so far? Did it add to some of your knowledge? Was this webinar helpful? If it is not a privacy concern, you turn on your camera. I mean, I'm not, no pressure, but I would be very glad or very I really appreciate if you have any feedbacks.
No, thank you very much, Dr. Farooq. This is a great refresher. I know statistics is always amazing but boring. It's not the pie for everyone. Some smart people who are deep in thinking and they do this. But it's always great refresher to know what currently companies are adapting and people like you are developing and establishing and then having the outputs. But with this development of the technology, particularly AI, which people still don't trust 100%, there is a lot of kind of caveats in accuracy. For example, when we do research analysis, and when I ask you, okay, give me the resources and the references, there is a big kind of gap. So then we have to put more time to correct those things. So with time and with the advancement, it's going to change. But thank you. This is a great refresher, and this is really helpful.
Thank you, Shafat. What's your background, Shafat? I know we have not met yet.
Yeah, I am a scientist.
Awesome. Awesome. No, you have a very great knowledge.
No, thank you. So it is just, just trying to learn more always. So technology. One thing about this output, when you write the message, there's a plus sign under message. So you can put it in a thinking or a research or analytical modes to make it more kind of refined outputs.
Oh, yeah, you're right. Yes.
Just
so,
I know you know
thank you
it,
for
but
bringing it up. Yeah, I noticed that too. So I used it a few times. Yeah, but thank you. But to your point, probably it will always be human plus machine. The dependence on total machine, at the end of the day, it's your responsibility, but it is enhancing your capabilities. I mean, in my case, I learned SAS back in 2014, 2015, didn't use it for a couple of years. Then I needed for some certain analysis. I have to relearn because I already forgot a lot of it. So I have to relearn for another couple of weeks, then do the analysis. Then I didn't use for another 2, 3 years. Then I have to relearn all those things. But when I come back to SAS, it takes me a week to get fully familiar. But
right.
Now, no more. I just use the knowledge I already have retained. I just put it there. Errors, I put it in ChatGPT. It gives me the corrections. So again, it's human plus AI. Of course, the capabilities and all human aspects of it needs to be there, but it is such a platform, such a enhancer that we got to be onto this train. This train is leaving. This is the biggest innovation of the history so far. And my life is totally shaped by AI already, and I mean, I use it to the extent I just asked this M3065. I have it on my phone. I just use it to ask, when did I change the tires of my car? And it gives me the details of all the tires that I changed in the last 5 years. It goes in all my folders, in all my emails, and it tells me, oh, you changed the tires of your car, and this much of the warranty is left. And I was at the tire shop last week, and I was at another. I took my car for some tune-up, and then it said that you need a new timing chain, and it takes 2,000. It will cost you $2,000. And I was on ChatGPT, and ChatGPT told me just ask him to change the VTEC solenoid, and I have zero idea what is the VTEC solenoid. And I said, why don't you just change the VTEC solenoid? It is going to cost me $100. And he was looking at me as if I am from Mars. And I didn't tell him who is guiding me.
Yeah, no, you're right. For the conventional marketing information, daily information, it's perfect. But when you talk about, let us say, we want to do the analysis of treatment, since we are clinical researchers and in a clinical research setting, when you look at the output, so we still need, like you are a SaaS expert, your expertise is needed to kind of look at those final outputs, even by the
Yeah.
AI.
I
So
mean, yeah, you're right. Like what Paul said, we still need these statistical tools for cleaning purposes.
exactly, yeah.
Relational databases, it doesn't. I tried, but it was not able to do anything for me. But I think it will change.
I know when I was a clinical research data scientist, how much time it used to take us to even kind of go through those tables and go one by one. Now we put in this system and it will give you the errors quickly.
Yeah. I will stop recording at this point. I do have 10 more minutes just to network.